Everybody hear me? It sounds like it. Okay, cool. For those of you who know me personally, you know that I love cardiacs, high energy, action, all the juicy stuff. And I inherited this topic, Introduction to Critical Care and Physical Assessment, which was a bit of a bummer. But as I prepared for this, I realized that it might be the most important thing that I do. Where to start in this nightmare? We all have a bit of ICU experience in this room, so I want you to imagine the best possible ICU. What does it look like to you? My Martin Luther King dream is the following. A multidisciplinary team using a scientific updated approach to treating critical care patients, their problems during their life-threatening illnesses. To predict and prevent further complications. It doesn't help to be the best resus team in the hospital if you keep landing at that point. We're trying not to get there. To have the same level of commitment to improve, educate, and stay on top of the latest research. We've all got education, but it continues. This field is so dynamic, it changes all the time. We need to stay up to date. Knowing your limitations. If you don't know something, there's no shame in putting up your hand and saying you don't know. Find out. Don't pretend like you know what you're doing and seeing. To create an environment where open communication is welcomed, that there's no hand, where a nurse's opinion counts, where the family member's opinion counts. Every member of the team must have a voice. Where experience and quality improvement is valued. I heard a rumor the other day that experience doesn't count. Tell that to someone who makes macaroons. To be a teacher, all of us need to teach. We've got such a terrible shortage of nursing staff and skills. It's up to us to teach and make this easier, make this burden easier, empower everyone around you to know what they're doing. To be hypervigilant and patient advocates regards safety, especially IPC practice. To put the patient first in all our decision making. Drop your ego, put it aside. You can pick it up when you go home. At the center of the multidisciplinary team is, of course, the nurse. Won't you just put it back? Okay. I was once told in the ICU, a doctor came to see my patient and she wrote some orders down and she said, "You guys are so cute. You're like medical waitresses." I was so fumingly upset about it, and it stuck with me for so many years. I think about it all the time. I really hope that that is not what nursing has come down to. Carrying out doctor's orders, doing a bed wash, and data collection of observations. I know we are worth way more than that. We have our own practice. We have so much to give. We intervene. We do so much. We're the center of this whole team and coordinate everybody's care. Advocate is irreplaceable and is certainly not. I wanted to share with you guys this amazing document. Please Google it. Whether you're a nurse or working with a nurse, you need to check out the SANC, which is the South African Nursing Council's competencies of a critical care nurse specialist. I just want to highlight some of them, but this document will pump you up. As you can see there, implements individualized, comprehensive-based care within a multidisciplinary collaboration. Look at what they talk about when we talk about data collection. Continuously monitors, interprets, and reacts. Okay, it's not just collecting the data. And obviously we want you to report the abnormalities, but it doesn't stop there. You can also react with urgency to a lot of the things we pick up. speaks up when appropriate to question critical care practice when necessary for safety and quality improvement. The Nursing Council says that's one of our tasks, to speak up. Okay, don't stand there with all these questions and concerns and just keep it to yourself. This is your role, okay? Let's look at some of the clinical things. They say that we can execute airway management ourselves, including intubation. If you've completed an advanced airway course as a critical care nurse specialist, this is within your scope of practice. No one's saying you are responsible for it and you have to do it, but this is the level you can achieve as an ICU sister. Performs effective oxygenation. You can choose the Airvo, the nasal cannula, all the different devices. It's in your power to administer oxygen. Obviously, we keep harping on multidisciplinary team. Initiate these conversations, but you don't have to sit back and wait for someone to come past to prescribe the device. Okay. They also encourage, determines readiness, prepares for, and performs weaning of critical ill patients from assistive technological devices. We can determine the readiness. You can introduce a nurse-led program for this. It is within our scope. Again, determines readiness, prepares the patient for, and performs extubation. Did you know this? Okay. Accurately records, analyzes, interprets, and reacts appropriately. They use that phrase a lot in a lot of the things. Okay, it's not just data collection, waitresses. Okay. Safely and confidently operates various types of technology. That is your responsibility, to get very well trained at all your equipment. Okay. You are the expert at the bedside. Actively participates in decision-making on transfer out. Can you believe that? How many times have you asked a doctor, is this patient ready for the ward? That is your job. Okay. Remember that story about 10,000 hours of experience to become an expert at anything, okay? Think of the doctors now, or the multidisciplinary team. How many hours they spend in the ICU versus the ICU sister. That's the only place you are. They're in their rooms and theater and other wards and all over the place. But the ICU nurse spends 12 hours, which is roughly about 5 years without overtime to become an expert. Whereas a doctor, 1-2 hours a day, depends what kind of doctor. But my point is you become the expert really quickly with the amount of hours you spend in this environment. I just wanted to bring your attention to something that I also discovered in this talk that is quite alarming. There was a study done on the gross shortage of certified clinicians and also ICU staff. They're not even sure how many ICU beds we have in South Africa. There hasn't been a count recently, and this information is not freely available. But they estimate around 7,000 beds, ICU beds. Currently, and this is current, the South African Nursing Council has just under 6,000 nurses for critical care, for 7,000 beds. That means there are people looking after patients that are not trained, obviously. Can you see how important it is that you're a teacher, that we invest in nursing, that we retain our staff and create a happy environment for them to work and not burn out? Don't have the answers to those questions, but it certainly is something to think about. I'm sure nursing is not the only field within the multidisciplinary team that is so short-staffed. There's a Daily Maverick article that also says that half of the nursing workforce is going to retire in the next 15 years. That's half of a already short-staffed system. It's very alarming. We need to promote it. We need to train more nurses with urgency. James, you were saying with doctors, how many specialists, what was the stat there? Yeah, 56 years old is the average age of a specialist in South Africa, a doctor. So they're in the same boat. It's very alarming to think about the future in our field. The Democratic Nursing Association of South Africa, DENOSA, actually said it's a ticking time bomb. So please, get involved in your culture in your unit and pick up the young ones and really train them and invest in them and make them enthusiastic about this. Okay, let's get on to a bit more fun stuff here. I wanted to ask you guys a question before we do that. Just want to quickly find. Can you guys name an ICU piece of equipment that is one of the most important things in the ICU? It's life-saving. It prevents ARDS. It prevents pneumothorax, compartment syndrome, aspiration pneumonia. Can you guys think what it might be? What is the most important piece of equipment in the ICU? A ventilator. It's a typical ICU sister answer. We always go for the big things, don't we? The fun and juicy. That's what I do too. Let me introduce to you a piece of equipment that you should be using on every single patient you come in contact with. The measuring tape. How many of you guys have this in your practice? Do you use it every single day? Okay. I will demonstrate to you how invaluable that is in a minute. I want to just highlight, because I'm not sure how much time I'm going to have to demonstrate. I will do a section, but the take home from the physical assessment is to develop your own practice and to keep it consistent. Okay. So you come into the ICU. Your assessment even starts with your handover. Let's not even go to how poor the handovers are. It's very rushed. It's unpaid time. The nurses have transport issues. Moms have to take the kids to school. It's a big mess, and it's a very slapdash process a lot of the time. Okay. In that climate, think about how important your own physical assessment is to gather your own information. Okay, so we take our handover, and then we go and do an assessment. Wrong. You're going to check if your patient needs contact precautions before you enter that room. When the night staff leave or wherever you took over, you've taken responsibility of the patient. You are now the patient's advocate, the patient's mouthpiece, and this area around the patient is now your domain, and the patient with that environment is your responsibility. You are responsible for the safety of this zone. So what are we going to do? Go drink coffee quickly. No. We're going to check our patient's safety. Okay. It is paramount to keep your patient safe and you. Okay. So check whether your patient has got any IPC considerations, and if you're doing an assessment, you're going to be touching the environment, leaning over cot sides and potentially infectious linen, all sorts. Put an apron on if you're getting in contact with the patient. Put an apron on, put gloves on. Do hand hygiene first before you even dream of doing anything else. Okay, get into this habit. Okay. The whole unit can be breaking down. Sister Charlie is calling you. There's phone. The visitors want to come in. We know the distractions. You must check the emergency trolley. This audit hasn't been done. Please explain what happened yesterday. Somebody wants drugs. No. You are going to check your patient first. Okay. And remember, Dr. van Roden, how many patients do you see when you're on an ICU rotation, like in a day?
About 20.
So say 20. I'm sure that it varies for all the different doctors, but you're the ICU nurse. What is the I in ICU? Intensive. You're the one that has one patient, maybe two. They have 10 or 20. How good can their assessment be? They're going to pick out the most important things. But you're the one that's got 12 hours with this patient. And I recommend that you do a head-to-toe assessment. A lot of our ICU charts have got guidelines on the back of what to check. And that's the bare minimum. We don't want to be bare minimum. We want to be from head to toe. Okay? We want to pick up everything and report it. Someone that's sedated and paralyzed cannot speak for themselves and tell them the back of their head is very sore. Okay? You need to find all these abnormalities. Okay? I want to quickly just go through that. You're going to need some equipment to do your patient assessment, maybe a Doppler, a torch, a stethoscope, an ENT set to look at the back of the throat. How many times do you look at the back of the throat? Go to a GP, they check it routinely, but if you're this sick and you've got a big tube in there, nobody looks. Nobody's looking at the details, and that, unfortunately, is the ICU sister's art, is in the detail. Okay, I want to quickly just demonstrate to you how I'd go about just checking the head quickly, if we've got time. So the first things first, even on the time crunch, there's no excuse not to check the IPC, even in a resus. Sorry if my mic goes wacky now. And if you've got long hair, whether you're a doctor or a nurse or anyone, you're going to have to wear a fun bun. Not just nurses wear fun buns, the whole multidisciplinary team, please. Okay. All right. I'm just going to do the head, I think. I don't have enough time. Okay, so we'll do our hand hygiene before this, but I just want to make a point of this is what it looks like. Okay, apron, gloves, all the time. So when you're checking the head, we usually start on a quick slapdash. We're going to quickly do the neuro-obs. Okay, it starts, go from top to bottom so that you don't forget anything. Okay. Check the occiput first. You don't even need to turn the patient to check the occiput. You can inspect it and lightly palpate it. And if you have a little bit of edema, yes, we're going to, on turning, maybe shave that area and see what's going on. There's a very common pressure sore in ICU, and it gets missed. Imagine if you don't do your patient assessment first thing, and you're only going to do it when you wash your patient after lunch. Look at the back of the head, maybe, if it catches your attention. It's going to be 6-8 hours of the patient lying on a pressure sore before you looked. How does it feel also when you do your neuro-obs later on in the day and you see a blown pupil? You have no idea when that started. Okay. It could have been at any time. You need to have a baseline when you accept the responsibility of this patient, the first thing you do. Okay. Okay, so we'll check the occiput. And we'll feel, and luckily he doesn't have one, because he's plastic. All right. Okay, in the eyes, we're going to do our neuro-obs, we're going to check our pupils, but there's many other things as intensive care nurses that we need to check. Okay, we're going to check for scleral edema. If you've got scleral edema, we know that it's connected to brain edema. Most likely you're going to have brain edema as well. Check the color of the sclera. Start looking for jaundice. Look inside the eyelid. Might give you a clue to anemia. Okay? Look at arcus cornealis, so that you might have a cholesterol issue, that nice white ring around the cornea. There's many other things that we can look for, and I encourage you, please, to go now after this talk and look nicely at how you're going to set out your head-to-toe assessment. I just want to show you also with the measuring tape quickly, the things that you can do. If you're a proper ICU sister, you're going to have a stethoscope and a measuring tape with you at all times. Okay. We need to check a proper height for this patient, a proper length, so that we can get ideal body weight, which we work out of ventilation, and we get lung protective tidal volumes. If you see a plus minus 1.7 on your chart, it means you're not an ICU sister. Okay. You're just a nurse. We want intensive care nursing. We want 167 centimeters, 172 centimeters, so we can work out intensively exactly how much volume to put in this patient. We're going to measure our lines. Okay, we're going to look after care and maintenance of all these devices and lines are on us. And we need to prevent this from migrating. How often do you turn your patient and here's the nasofix outside? This nasogastric tube is migrating all the time. Okay, so please check the length. This goes with a Koki pen, all right? Kat, can I ask you quickly to also just give them out? Please invest in a Koki pen and make sure you know the centimeters, how much must be sticking out of this patient. IC drains, the same story. Please measure them, put it on your chart. And once you've completed your assessment, check the previous person's assessment. Okay, check and see, has there been any changes? And all the care will be directed from all these things. I asked them to add a column on the register, and I'll give you that information a little bit later. But the strength of the ICU, the brilliant ICU that you see, is not in the pretty building. It's in this room. It's the years of experience, and it's the people you have. I'll give you a tally at sometime during our talk of how many years we have in this room. We just need to enforce this expertise. Thank you very much.